Yeah, thank you guys for having me. GLP-1 receptor agonists, obviously, we're hearing a lot about them, but I want to share some real-world evidence from a phase 4 clinical study that was conducted in California by a colleague, Dr. K. Raj. And um, as we've mentioned, GLP-1 receptor agonists, they're growing. This is some, I think, really interesting Google trend data. No one is probably surprised by the top graph on the right. This is just Google, normal Google searches for GLP-1 receptor agonists, but Google Trend also procures you related searches. So the same people that are searching for Ozempic also are searching for Ozempic face, plastic surgeons, Ozempic face, before and after Ozempic face. Meaning the people that are seeking out these drugs, GLP-1 receptor agonists, are acutely aware that they are associated with aesthetic complications. So what does that actually look like? I think for the average person, we see facial narrowing, lipoatrophy, and deepening of facial folds like nasolabial folds and marionette lines. So the parent study that this idea came from was a 24-patient lower face hyperdilute radius study. So not looking at radius from a filler perspective, but from a hyperdilute biostimulatory perspective. So Dr. K presented this data at a conference that we were both at, and I noticed that she had 4 patients that were non-responders. And I'm always interested in why patients don't respond to a treatment. So I was like, we should go back and look and figure out if there was some commonality between these 4 patients that weren't responders. She had a pretty standard treatment, 2 treatment sessions at 0 and 4 weeks. She used a 1-to-3 hyperdilution of radius. So earlier this year, one of my collaborators, Dr. Akash Chandawarkar, and I took a peek at the rheology of hyperdilute radius. And at a 1-to-3, there's no direct filling. There's no direct volumization. So any aesthetic correction that we're seeing is the result of biostimulation. Anyway, we pulled these 4 patients out at the end of her parent study and realized that all 4 of them were on GLP-1 receptor agonists. And between these 4 patients, they were all on different GLP-1 receptor agonists, but they had lost an average of 24.25 pounds. And this was a 6-month study. So this is approximately 10% of their body weight that they lost over a 6-month period. But most notably, despite being statistical non-responders in the parent study, we noticed that they preserved facial volume. Now, the good part about the clinical study that we ran was we included photogrammetry. So we had both volumetric and line depth measurements. And I think you can appreciate just with before and after photos, these patients lost 36 and 34 pounds respectively, but still seem to maintain a decent bit of volume in their upper cheek. And that's exactly what we saw. So this is a lot of data, but to summarize this, over 6 months, and despite these patients losing about 10% of their body weight, they actually had an increase in cheek volume. They had decreases in jowl volume, decreases in nasolabial fold depth, and decreases in marionette line depth. And I think you can appreciate visually what that looks like. So to me, pulling these patients out from this parent study, these are patients that are concurrently losing weight, seeing volumetric redistribution in the area that was treated with hyperdiluted radius, signaled to us that these patients, despite being in a catabolic state, could preserve their upper face or their mid-face volume. And I think if you really wanted to summarize the experience of these 4 patients and get a good objective glimpse at the role injectable biostimulators might play for GLP-1 patients, it's this graph. So we see a divergence over time, right? This is not an immediate fill. This is not an immediate effect. You see gradual volumization in the cheek, the area that's treated, that really peaks at 6 months, but you see that diverge from the weight loss. Patients were also satisfied. I thought this was some of the most interesting data because if you think back to the parent study, these were patients that, according to that data set, were not significant responders, but why were they satisfied? I think it gives us a glimpse into some of the psychology of the patient that's on a GLP-1 receptor agonist. Perhaps they know that they're losing weight and maybe anticipate some facial lipoatrophy or worsening of folds and wrinkles, but in this case, that's not what they saw. So they saw a great preservation of their mid-face volume. and that's reflected in a gradual increase in patient satisfaction. And as I mentioned earlier, the mechanism of action, especially for a hyperdilution of CAHA, is not filling. And that's why when we look volumetrically, we actually see a decrease in volume at month 1, and then we see that increase throughout month 6. So this is at a 1 to 3, we have approximately 2 pascals of G prime. This is essentially water with CAHA microspheres in it. So our bulking effect, or our tissue strengthening effect, is neocollagenesis, and you can see that captured quite nicely in the trichrome stain on the right. So some conclusions. Hyperdilute CAHA preserved facial volume in these subset of patients from this parent hyperdilute lower face radius study despite their concurrent rapid weight loss. We saw improvements in wrinkle depth, we saw some jowl tightening, and we saw patient satisfaction that was in line with what you might expect from a biostimulator. So a gradual response that really increases and maybe peaks around month 4 through month 6. And we saw that preservation of mid-face volume is important for preventing worsening jowls and facial lines during weight loss. I didn't include this graphic because it looks like a correlation table, but I took the percent change of weight, of volume, and of line depth, and wanted to see which variables impacted each other. And from this correlation table, you could see that maintaining cheek volume was a very important predictor in reduction of jowl volume. So for me, that was also a really cool thing to sort of statistically map out. We also know that biostimulators' mechanism of action is not one of filling, but one that stimulates collagen and other structural proteins by activating fibroblasts. This is why I think in any of these studies down the road, we'll see a gradual response over time. But we definitely need more research, and that's something that we're currently working on. So what does an optimal cadence look like? Are there optimal dilutions? And what would a treatment plan with concurrent weight loss look like with biostimulation? And with that, I will hand it over.